Thank you, chairpersons, and welcome again to all the dear members, faculties here. To begin with, let me first of all declare that this presentation is basically, we are trying to balance between two fields. Neurosurgical field who think everything can be cured with a knife, and epilepsy surgeon who thinks everything is an epilepsy. So that's why we wanted to make a very tight balance amongst each. And then what we have been trying in the last 4 presentation had been that, look, there's always an epilepsy component in everything which we see in our daily OPDs. We may look at a brain tumor, we may look at a infection, we may look at a hydrocephalus, but then sometime even after doing a surgical maneuver, surgical intervention, in these cases, patients do develop epilepsy after a certain time, and these are very chronic and that needs to be addressed. Now, I bring forward some things in my presentation here, which may be a little bit of brain tickling, and that's why we can actually invite more discussion on that. To begin with, I will just like to explain the term lesional epilepsy. This is not mine. This is from the literature. And what it says is recurrent seizure due to tumors, vascular malformation, infection, or congenital anomalies, either picked on imaging or histopathological examination, and which they say by removing or the lesion may cure a patient with epilepsy. And that's why I put it in italicized, because that's not always true. We may be hitting on some other target, the epileptogenic focus may be different, and that's why that needs to be addressed. And that's why lesional epilepsy, even though MRI have made our life very easy by bringing or highlighting the lesions forthward, sometimes we are misguided. We see a lesion and we jump upon it rather than exploring the patients in detail and working the patient in detail. And that's what we are going to talk about in the next few minutes. What we need to consider is whenever we consider a diagnosis of lesional epilepsy on histopathological examination, it's a retrospective diagnosis. We may not have got it in the MRI, nothing. It's just because we have got did an SEEG or a subdural grids, and we have done some video EEG, and we have localized a lesion. And then we excise it and you find there's a FCD sitting inside, or there may be some other pathology there. So there's a retrospective diagnosis in that condition. Yeah, and also in focal onset epilepsy, even though the word is focal onset epilepsy, even which recommended by the ILA this time, not all focal onset epilepsy will have a lesion inside it. So MRI may be negative. So that is something which we need to consider. And now with the advent of the fresh electrophysiological modalities of investigations like invasive or depth electrodes, we are able to localize those lesions which are absolutely MRI negative, despite of doing repeated imaging. And hence, that brings forward a point. Are we actually talking about lesional epilepsy or something else? Should a new term be there? Initially, if you remember, ILE had recommended a term known as localization related epilepsy. Now, the problem with that terminology was that most of the diagnoses were idiopathic, and henceforth that there was no treatment for it, no surgical treatment available for it. So that's why a new term may be suggested, and this is just my thought process. I may be wrong. Maybe something like localizable epilepsy, where we could actually localize the lesion not only on MRI, but also on depth electrodes or invasive monitoring, and then try to hit on the diagnosis or the treatment of the patients. Now, if you see the classification of the lesional epilepsy, again given by literature, they have divided it according to the place of location, temporal, extratemporal, or subcortical lesion epilepsy, and then they have identified various pathological reasons for it. And there may be another component known as catastrophic epilepsy, which is seen in hemimegalencephaly, diffuse cortical dysplasia, Rasmussen's, or porencephalic cyst. Now, these most often are surgical conditions, and henceforth they need to be discussed in terms of a lesional epilepsy. And a simple classification could be congenital and acquired. Now, why does it matter? Because when we talk of epilepsy surgery, there's a gamut of procedures one can perform, ranging from lesionectomy, which most of the neurosurgeons perform on looking on a brain tumor or AVM or any vascular malformation for that reason, to tailored resection, to something known as hemispherectomy or disconnected surgeries. Now, it all depends upon what philosophy we are taking in these management protocol. Are we trying to remove the lesion only? Are we trying to remove the epileptogenic zone? We are trying to block the seizure spread. We are trying to block the disease progression, or we are doing a functional intervention in terms of neurostimulation or a neuroablation. So these all things are there now in the armamentarium of an epilepsy surgeon as well as a neurosurgeon for that matter. But then it requires a lot of detailed workup rather than just sitting in OPD, see an MRI and just take the patient to the theater, because there's a lot of things to be done. Now, I just share with you two experiences here. This is a patient who had a left temporal grade 3 anaplastic gangliogloma, recurrent seizures for the last 3 months. We had operated him, and then we did an anterior temporal lobectomy and amioductal hippectomy, and the patient got the Engel's class 1 result after the surgery, and he was in our follow-up for the last 4 years. Then another case of a 9-year-old kid who had left hemisphere encephalomalacia present with recurrent seizures, intractable ones. And we did a peninsular hemispherotomy, and the patient could be decreased to level 2 in this patient. So when we're talking of a palliative procedure or a curative procedure, it cannot be done in every patient. There are a lot of things which decide, and the most important thing which decide is the cause and the location. And that's where the lesional thing or the MRI thing comes into picture. Now, I will just like to share a recent meta-analysis which was published in Medicine 2019, where they have pulled all the patients who have been started with antiepileptic drugs, the patients who have been freshly diagnosed with epilepsy, and they found that almost 25% patients had a drug-resistant epilepsy in their cohort. And when they're trying to find out the reasons behind it, the major reason was again a symptomatic etiology. So there was a lesion sitting inside, and that was not managed in time. Or the treating doctor must have thought that the lesion may not be too much of importance. So that's why he kept on treating the patient, and the patient develops a drug-resistant epilepsy. Now I'm going to tell you the effect of delaying the treatment also in the future slides. Now, another topic which I want to, the work which I want to share is this meta-analysis on the surgical patients. Now, this surgical meta-analysis was on 40 articles, which was published since 1995. And then they have group 2 patients, non-lesional epilepsy versus lesional epilepsy. And they found that the patient who are lesional epilepsy have 2.5 times more chances of getting cure of their epilepsy. So this means we are going to have a better results if we are going to find out these sort of patients and try to help these patients out. Now, why this happen? Why there's a difference between a lesional epilepsy and a non-lesional epilepsy? Why this is the change or the difference in outcome? Now, it has been seen that the cortical lesion is substantially very much nearly located to the epileptogenic zone. And that's why trying to remove this cortical lesion, somehow we are trying to remove the epileptogenic zone altogether. So that is maybe helpful. And that's why it actually gets us to a more effective resection. Similarly, when somebody sees a lesion on the MRI, patient jumps on a treatment faster. So chances of delaying the treatment for a later period is far lesser in those patients who have a lesional epilepsy as those patients who have non-lesional epilepsies. Similarly, in non-lesional epilepsy, there can be multifocal seizure onsets. There the failure of the scalp or the intracranial EEG to pick up those signal changes. So this may also lead to the failure of diagnosis at the proper time, and the treatment could not be given at the earliest phase. The dilemma is that, as we have already spoken, Dr. Panta was also speaking about it, sometimes the lesion may not be near to the epileptogenic zone. The epileptogenic zone may be located far off from the tumor. Now, these are the patients which we get easily missed whenever we are sitting at a neurosurgical OPD, are looking at the patient at the only angle or the viewpoint of a lesion present on an MRI. So whenever patients present with epilepsy, the patient has to be managed as an epilepsy patient rather than a patient with a brain tumor or vascular malformation. Now, this is, I think, first one of its kind publication from Cleveland Clinic, a 20-year-old longitudinal analysis of all the patients they have taken for surgery for epilepsy. And what they found that over the 20 years period, there's almost a 58% recurrences in the results. Even though these were the people who reported best results in the first 5 to 10 years of their epilepsy surgery results, after 20 years, they find almost 58% recurrences. And they did a very extended analysis on this. This was published only in 2020. And what they found is almost 55% patients, they could not explain the reason why the patient had the recurrences. And that's why only a very small set of patients, that is 12.3% patients, underwent a reoperation for their recurrent seizures. Incomplete resection was found to be only in 8.8% patients, and those were a minute of those. I think only 3 patients in their whole series were having a dual pathology for this particular reasons. Otherwise, mislocalization was there in 36.3% patients. So that means a lot of work need to be done, even though they have worked up most of the patients in the first surgery itself. So they have actually concluded that the first surgery is the best attempt one can make to control seizure if in case you are targeting the patients for a cure of epilepsy for the lesional epilepsy. So the first surgery is the best, because even though you may get a good control after subsequent surgeries, the outcome ratio is not that high. So the first surgery is something which is very important. And they also have highlighted a new term that is known as surgical refractoriness, which they have said that maybe because of those 55% unexplained conditions or cases, there may be a scenario where the patient have developed a surgical refractoriness because of the long duration of seizures, and that's why the clinical phenomenon and a lot of this thing have already occurred in the patient. Now, that actually brings up to this point of concordance. Whenever we see a patient with a lesion with an epilepsy, we should always undertake the first line of a first phase of evaluation as we do an epilepsy surgery. That is, we need to have a concordance with the semiology of the patient, that is the ictal semiology of the patient. We need to have a concordance of an inter-ictal EEG. Now, this is very important in our place in Nepal, because most of the EEGs only report whether the report is abnormal or normal, rather than localize the disease for us. Because if in case a localization is given in straightforward, it becomes easy for us to discuss also on that particular line. Ictal onset EEG, which can be picked up on a video EEG by admitting the patient and then monitoring into the electromonitoring unit. Of course, the MRI needs to be discussed with the radiologist as well as the neurologist in the same room, sitting in the same room, so we can have a lot of ideas forthcoming. And of course, neuropsych evaluation is very important to see what all deficits are we going to see in future after the patient underwent surgeries. And if in case the concordance is not there, we should go ahead with us level 2 studies. So in terms of metabolic studies like PET or ictal SPET or SysCom. So this is just a table of epilepsy surgery, which we all know. But then what point we need to make is that surgery for a surgically treatable lesion with epilepsy is an epilepsy surgery. So as rightly pointed out by Dr. Pant and Dr. Pravesh, we should actually take these cases as epilepsy surgery rather than a simple excision for brain tumor or a vascular malformation. We are actually dealing with a completely different condition. So how to suspect a lesional epilepsy? That may be happening to everybody of us. We may be sitting in OPD and a patient comes to us with a seizure episode. So should we evaluate the patient with our imaging? Now, these are the certain things which again have been highlighted with most of the researchers. Partial onset seizure and history or EEG or occurrence of a status epilepticus demands an imaging. So whenever you have this type of cases, you should always get a MRI at least. And also get a new, if in case a patient has a new onset or a progressive neurological or neuropsychological deficits or features of raised ICP, then again demands an imaging. Repeated seizure despite proper doses and compliance, that is intractable seizure. Patient is having a change in pattern of the severity of the seizure. The pattern on the EEG is changing. If there's a relapse after initial remission, or if in case there's a generalized seizure which appears in the early years of life, that is less than 2 years of age, or an adulthood the first time, this again needs to be evaluated thoroughly, because sometimes we may be missing things. So before we start or change the treatment for epilepsy, look for the cause, and this is something which we should all do. Now, how to improve the diagnostic yield? Neuroimaging for this epilepsy condition is very important, because it not only detects the seizure, helps to identify a possible location of seizure onset zone, but also predicts and prevents deficits from surgery, and also eliminates mechanism of epileptogenesis. MRI is always the first line of investigation rather than a CT scan, unless until there's an acute condition, we're thinking of a vascular lesion or there's a calcified lesion, then a CT scan makes a sense. Otherwise, we should always go for an MRI. Now, there are 4 things which has been identified by most of the literature to have a high yield diagnosis. One is definitely the field strength, that is a 3 Tesla or 1.5 Tesla or 3 Tesla and higher. If in case you have a 1.5 Tesla, you should use a phased arrow coil around the head so as to increase the resolution of your images, as well as you should have an epilepsy protocol as to how you scan the patients on an MRI. Most of the centers who are doing an epilepsy protocol, they are doing even now a half-hearted epilepsy protocol. Now we will be discussing that also in the next slide. And also the 4th and the very important component is that these radiologies should be discussed by a dedicated radiologist who's involved in epilepsy care, and should be discussed amongst the team members, including the neurosurgeon and the epileptologist in the room. Now, this is just a recommendation by again ILAE regarding what type of MRI you require for hippocampal sclerosis, and the second box is for other conditions. So in T1 weighted image, we need to have basically a 3D image, and then T2 at least in two different planes. We should have a thin sections, we should have a flare, Apart from that, DWI and DTIs are very helpful. DWI will help you to know whether this is a vascular involvement or vascular edema associated with not. SWI helps us to identify a bleed. Arterial spin labeling is a new, rather it's not that new, but even it's new for our Nepal. This basically tags water molecule which is flowing inside the blood vessel. So that's why it is as good as a perfusion based images. So if you do not have a perfusion images in your place, you can actually ask for an arterial spin labeling on an MRI, and this can also give you perfusion images on your MRI. And of course, even with contrast, if in case you are thinking of a vascular lesion or a tumorous lesion. DTIs are something which are now upcoming. Why? Because they will help you to show the pathway, and the anisotropy between the two layers or two sides can help you identify or literalize the lesion. And it can also tell you about what type of language or motor or a memory deficits one can actually expect in these patients. So the other tracks like arcuate fasciculus, uncinate fasciculus, or IFOF, they help you to understand these types of anomalies or deficits in the patients. Now, this is just a slide to let you know what type of changes one can see. So this is a MRI of a status epilepticus patient. And usually we all know in a status epilepticus patient develops some type of vascular edema or vasogenic edema in the brain. And you can see there's a cortical thickening in the frontal lobe. This is basically a DWI image. And then the subsequent ADC shows restriction of the images. And then in the flare also, you have subtle different changes in hyperintensity. But again, when you do a contrast, you do see a very high uptake of vascular edema. So these type of different protocols, when you're using for epilepsy imaging, that help you to diagnose the condition much better. Now, this is a very important talk where I'm going to talk in two different slides. What is the role of repeated imaging? Now, this paper was published in Korean Journal of Radiology, where they have done a 15-year-old period study repeating the MRI. They have actually made two epochs, one with a 1.5 Tesla, the other one was a 3 Tesla MRI. And what they found is that repeat MRI actually reveals around 21% positivity, with almost 50% of the patients identifying an epileptogenic focus on MRI. And what were they finding out in this repeat MRI was focal cortical dysplasia, hippocampal sclerosis, polymicrogyria, heterotropic gray matter, microlesioncephaly, cortical tumor. Now, these are all small tumors which are easily missed on 1.5 Tesla MRI, unless until you have a dedicated radiologist and an urge to see what is going in within. So, and then they found that almost more than 90% reasons for failing to identify was radiological, and they were actually comparing two machines, 1.5 versus 3 Tesla. Apart from that, these authors also said that if in case a person has got scanned less than 2 years of age, that is the age when the myelination has not yet developed completely in the brain, one should actually undertake a repeat MRI in these conditions. Now, this is just some small example now of a focal cortical dysplasia. You can see in this particular scan, there was a little bit of subtle cortical thickening, which was done at the age of 3 years. But then when the child's MRI was repeated over the period of next 7 years, the lesion became much more prominent. So FCDs or cortical dysplasias, sometimes they get picked up on a repeat imaging after a certain period of time. So one should remember that rather than just negating the MRI on the first hand. Similarly, this is an example how an improvement in imaging can help. So this was in 1.5 Tesla, this was in 3 Tesla. And you can see again the focal cortical dysplasia and the frontobasal area, and you can see this is subtle thickening. It can be or cannot be, but it is very well evident on the 3 Tesla MRI on a later date. Now, this has also been shown to be helpful. Repeat imaging has also been shown to be helpful in adults with chronic epilepsy. And this was a study which was again done by over 804 patients. And what they have found that the change in diagnosis was made in 26% patients by repeat imaging, and which have helped them to identify 5% new lesion. One other thing which they have highlighted by this paper was that in chronic epilepsy, say for example, you may have seen a patient of a hippocampal sclerosis on a right side. What they have found is that over a period of time, because of kindling phenomena, because of various other reasons, hippocampal sclerosis have occurred in the other side also. So sometime you may see a burnt out condition. So you may be thinking in the first hand, a patient of a lesional epilepsy, put him for this surgery. The patient did not follows after 4 or 5 years down the line. The patient may have a complete different pathology going inside his brain. So that needs a further demands a further investigation. So this particular study actually highlights the need of repeated imaging in these conditions where we may be avoiding certain unnecessary surgeries in these conditions, which are bound to fail even with a circuit surgery. Now, all MRIs are not helpful. If you see the types of lesion one can identify based on MRI, these can be classified on 5 different types. There may be some non-specific abnormalities like periventricular leukomalacias, atrophy, never related to the seizures or epilepsies. There may be some static remote lesions like porencephaly or MCDs. There may be focal lesions. Now, this is something which is very important for epilepsy surgeons. There may be some focal lesions which are responsible for seizure but do not require an immediate intervention. And the other two groups are subacute or chronic processes like brain tumor or leukodystrophies or metabolic disorders, or maybe some acute processes like hydrocephalus or acute stroke. So one has to see that these different types of lesions which appear on MRI, they demand a completely different type of surgical approaches. So that's why we have to be cognizant of this fact also. Now, if in case MRI is negative, despite of repeated imaging and everything, do not leave the case there and then. If in case you have identified it to be a focal onset seizure, one should actually again go and look back into the seizure semiology. Seizure semiology has a lot of good things hidden inside it. It will not only help you to localize the lesion, but also have lateralizing value. And it has been shown in studies that these types of seizure semiology are at par to interictal or ictal scalp EEG and MRI in certain cases. So that's why ictal semiology has to be worked up in all the patients, even if in case the MRI is negative, to go back again and look into these scenarios. Or they may demand an invasive monitoring in these cases where we need to undertake an invasive monitoring to find out the focus of the epilepsy. Now, my previous speakers have already told certain types of risk the surgery puts the patient on of seizure, and definitely that's true, because in animal studies, generations of free radicals, imbalances between the ions, as well as release of excitatory amino acids have caused post-seizure, post-trauma like operations or post-surgical seizures. So that's why all these operations, so neurosurgical procedures done on a patient, they are considered equivalent to a post-traumatic seizure in terms of the time course. And that's why ventricular shunting or patients with intracranial tumors or AVMs for that matter needs to be followed for a longer period, because they may show a delayed seizure on a later date. Now, we all practice that 7-day protocol, but that was basically also my understanding that 7 days is something which has been proven by some guideline or supported by guideline. This is just to share with all of you that this particular guideline, which was given by ILAE, is now been, American Academy of Neurology has now been retired. So if in case we are using those 7 days prophylaxis protocol for perioperative care, this is a retired guideline. A new fresh one is being made, but in the website of AAN, they have said that this particular guideline is retired. So that's why this is just to share with you all that if we are using any antiepileptics as a prophylactic drug for any of the lesional epilepsy, it has not been shown to have any prophylactic role till date. So whatever we are using is just for our own clinical practice to keep ourselves safe. So this is just a synopsis of what Dr. Bidur has already told, so I'm going to skip it. There are certain surgical measures to achieve good epilepsy outcomes. If, for example, use of perioperative steroids, because it helps decrease the vasogenic edema, so it helps decrease the chances of seizure and henceforth epilepsy on a later date. Intraoperatively, use of ECOG is a very, very vital thing, particularly if in case you are thinking of a dual pathology or a remote sites of epileptogenic zone. Bloodless field is something which we all like to maintain to avoid seizure in the post-operative phase. So that's why we should need to irrigate the field of the clot and the foreign bodies after this surgery. Hydrogen peroxide and cautery are something which we are also using in most of these scenarios whenever there's a lot of bleeding, but then mind you, this can cause post-operative seizures. So that's why this has to be used very carefully, minimal cauterization. And if in case one is using hydrogen peroxide, always use it with a cottonoid soaked in it rather than spraying the hydrogen peroxide over the brain directly. And then, of course, the follow-up parameters like doing and interictal EEGs in the follow-up is very important, because sometimes this may help you to predict these seizures. But even though I'm saying so, the evidences are not completely in favor of it. There are various evidences which show interictal EEGs cannot predict the occurrence of seizure in the post-operative phase. So even though there's an issue on this. Now, there are certain favorable outcomes and non-favorable outcomes, which we have already discussed in detail. Now, what's new or developing in this field of lesional epilepsy is the gamut of investigations which are now available with us. MEG Even though it's not available in Nepal, it's very much available in India, in Delhi and Mumbai. So if in case if one of the patients requires MEG, they can be transferred, they can be referred to these places. MEG actually helps us to pick up the magnetic dipole, which is generated during the seizure event. The problem with the MEG is that it does not picks up the deep-seated lesion. It will only pick up the superficial. But the best part of the MEG is that it gives you a very good spatial resolution as compared to the EEGs or source imaging using an EEGs, which are very good for temporal localization rather than a spatial localization. Similarly, PET and SPECT are metabolic based tests, which Dr. Shah has already highlighted earlier. And then high frequency of oscillation are something which is a now upcoming thing. High frequency oscillation is very good to pick up the ictal onset zone. Why? Because it has been shown that even after the patient has gone into a frank seizure, unlike the EEG, which gets actually bizarre after the patient have a seizure, the HFOs remains intact. They do not get obliterated. Henceforth, even in case of a network-based epilepsy, HFOs will be able to help you to pinpoint on the focus. And then stereo EEG is something which is in thing. Centers in Nepal have been doing it, and we have recently bought a robot also to put an EEG electrodes. The idea was to get in Visualize, but then there's a lot of administrative hurdle for it. So Visualize is a laser ablation using the pathway which has been identified by SEEG to ablate the networks and then inside the brain itself without opening it up. So Visualize is a very good modality, particularly for the brain tumors as well as for the epilepsy. So these are the new things which are coming up in lesional epilepsy. And then just to have a concluding talk on this, so we will just abide by what Luder and Awad said in 1992. The whole idea of epilepsy surgery is to remove as much possible as presumed epileptonic zone with a minimum of neurological and cognitive deficit. So this is slightly different from what neurosurgeons do for tumors. That is the safe maximal excision. In this epilepsy surgery context, we actually do a safe excision of the epileptogenic zone as much as possible. And of course, this concordance table is something which you all need to follow. Before I conclude, I will just like to put up this slide from Usual et al. In 2012, which is also relevant in our context. Substantial underutilization of surgery as a treatment of epilepsy has been seen all over the world. Even in the developed countries also, the surgery as a treatment of the epilepsy is being underutilized. And that's why surgical evaluation must be a priority role in all the refractory patients. So to conclude, lesion epilepsy is an evolving concept. As we are looking at through the duration and pulling up a lot of new investigations coming up, maybe we will be not talking of lesion epilepsy only in terms of MRI-based finding, but also a lot of other things which will be picking up lesions in days to come. Long-term outcome is much better than long-lesion one. There's no denying this fact. Suspicion is the key. So unless we do not have a very high index suspicion, go back to the patient and look for it. We are not able to hit on the diagnosis, and the chances of missing on this particular element is very, very high. High quality cranial imaging is always a yes. So repeat if needed. However, a non-lesional MRI does not negate surgery, and surgical approaches need to be tailored. And also follow-up electrophysiological studies are very, very important, which we as a neurosurgeons are doing lesser often. So that's why we have to do these things as much as possible. So with this word, I would like to say thank you for your patience listening, and invite any questions in the end. Thank you.